Nancy Laval from the Maryland Hospital Association, also for my program.
Patricia Roddy, DHMH Medicaid.
Ann Meck, University of Maryland School of Nursing.
Stu Gutterman from the Commonwealth Fund.
Julie Chilukolu, HCRC. And who do we have online?
John Hamper, Care First.
Ray Gray.
Mary Braid Forbes.
Okay, well, thank everybody for being here. We have several things on our agenda for today. We wanted to start by going through and explaining where we are with the market shift calculations and the progress that we've been making, followed by it's January. It's time to get started on the fiscal year 2016 update process. So just getting started on that process and discussion, and also discussing where we are with uncompensated care adjustment process and what we're thinking about for fiscal year 2016. So with that, we'll turn it over to Shule and start talking about market share. And before I go into the calculation, some of you already followed the commission packet, but for the rest of you, the principles that we've been discussing at the meetings now is part of the commission packet for them to review and provide us some input and comments back for the meeting coming up in January. The market share calculations, as we discussed before, I wanted to just kind of start with the unit of analysis. If you remember, we had discussions about, doing it per patient versus per visit. At this point, we are still focusing on a per visit type of calculation, but we are very interested in a per patient type of analysis, and hopefully we'll work on it once we figure out the service line ones. On the inpatient one, we created service lines based on APR DRGs, and this is a relatively simple reclassification of DRGs into the more aggregate service line concepts. And it's developed by 3M originally, but we made some modifications so that the specific service lines are separated, like trauma and transfers. Transplant. In the inpatient one, we have the potential avoidable utilization measures, readmissions, and PQIs, preventive quality indicators from ARC, that we use in other payment programs as well, where we expect utilization declines, and we don't want to include them in our market share calculations. And on the outpatient service line, it's more complicated because we have multiple codes and multiple services provided per patient in a per visit basis. So we are still working through it, but what we are doing is basically we are trying to assign the service line to the highest resource utilization category. And these service lines are ED, and then major surgery, minor surgery, and pathology, and a few others. We decided for the initial phase to separate oncology, radiation therapy, and drugs and work on them separately because these are services where there are recurrent visits. And in our data, when we look at it, some hospitals are submitting one claim per visit. Some hospitals are submitting one claim per month. So when we try to do weights or counts, you can't really count, similarly for all hospitals. So we separated them, and we are going to find a way to count them in a different methodology. And we are looking at maybe counting patients. Since we have CRISP ID there, we may be easily counting the patients, or we may do some revenue-based calculations that we did with other analysis before. And finally, once we count the visits and then adjust for the case mix,
we convert the outpatient visits into an inpatient visit by the charge ratios. If you remember, on average, the inpatient visit costs $12,000. On the inpatient, it's about, I don't remember, 4,000 or so. So there is a big difference in the visit counts between inpatient and outpatient. So what we do is we convert the inpatients, so we rate them less based on the charge ratio. And did you remember the outpatient number? 8,000? No. No. 10 times, right. All right, anyway. So that's how we come up with a unit of analysis for the market share. So we are still counting services provided to patients, and it's risk adjusted, so we value the visits that are more expensive or require more resources. Then on the inclusion, since we have the Maryland residents in our data, I just wanted to make sure we are all aware of the limitations of the market share calculations. We are looking at Maryland residents in Maryland hospitals for these calculations because we don't have data for out-of-state patients in out-of-state hospitals. So we would need to think about, outside of the market share shift, how we are going to handle non-Maryland resident utilization, and also how we are going to look at if Maryland residents start receiving services outside of the state. And also the shift to unregulated space, sometimes the declines that we see in our data may be a reflection of changes in the services provided by a hospital. So just give an example, this was a data issue, but it could have been the real issue. For GBMC, we noticed that there was a major decline in their major surgery service line. Turned out because they didn't submit their CPTs, it's corrected now, so it's not an issue anymore. Let's assume for a minute that GBMC used an unregulated space and majority of the major surgery went outside of the hospital. In our data set, what it shows is the market shift to other hospitals because other hospitals were increasing their services. So we need to make sure we link up with our GBR agreements. When hospital moves services outside of the regulated space, we make adjustments in our calculations so we don't reflect them as market shift to another regulated facility. And lastly, the calculations are done at the zip code and service line level. So that minimizes the impact of utilization declines that we see per hospital. So conceptually, you are looking at a very small geography and looking at the utilization in that geography. So if there is a utilization decline based on one hospital doing community-based interventions, you would think that all the utilization, including other hospitals' utilization, should go down. So there is a less chance of having a miscalculation of the market shift if you use a small service line. If we were to use an aggregate state average, then all these changes underlying may reflect a false totals because underlying changes are very different for each hospital. Even though it's good to use the smaller geographies, we are still looking at some zip codes where maybe there is not much competition and aggregation makes sense. So for especially TPR hospitals, only a few hospitals may be providing services to certain zip codes. And if there is no much movement, we are thinking about aggregating and creating a maybe county-based calculations for a zip code that has similar services and similar providers year over year. So let me stop here first because I know I went a little bit fast, but I wanted to make sure that at the high level you have a good understanding of what the measures are so far. All right. Anyone on the phone who has any comment or question? All right. So then this slide was from previous presentations we had on the formula that we were using. And one of the main principles of market share, if you remember, we wanted to separate utilization increase from market shift. And to avoid giving credit for utilization increases, because our whole model is based on utilization control and reducing the avoidable utilizations, the way that we designed the formula was we were looking at the hospital A utilization. So this is our hospital where we are calculating the market shift. And then all other hospitals. So what is happening to the all other hospitals in this same zip code, in the same service line? So in this example, the example is general surgery, and this is one zip code, let's assume. In hospital A, you see 500 additional cases. So for us to count this as a market shift, we said the other hospitals have to have a decline so that we would award a market shift for hospital A. If all other hospitals are also increasing, we have no way of knowing how much of it is a market shift, how much of it is a utilization increase. So we said we are not going to give any market share shift if both the hospital A and all other hospitals had the utilization increases. In this example, hospital A is increasing by 500 cases. The other hospitals were declining by 800. So in this case, we are saying there is a potential market shift here because hospital A gained, all other hospitals are declining. So there is a shift from other hospitals to this hospital. But we wanted to limit the shift to the lesser of the two numbers because obviously hospital A didn't gain all the 800 cases from other hospitals. They only increased by 500. So the limit here for hospital A was 500 additional cases for market shift. If the decline wasn't 800, but let's say 200, then hospital A was going to get only 200 cases, even though their increase was 500. So this is how we handled the separation of market shift from the utilization. So
hey,
everyone
Julie,
likes.
This is John.
Yep. Mm-hmm.
Quick question, and I understand this, and this is fine, but in our example where we had proposed, like if it's a panel through an ACO or a primary care medical group that works with a hospital, and they approach the commission in advance with a plan and to move certain cases from hospital A to B, I mean, that would still fall within, I mean, to me that would be like an exception, and you would still accept that approach rather than just looking at the numbers completely?
So I will get to it towards the end. So this is how we are going to try to calculate the market shift. So in that example, if we do something prospectively, at the end of the year, we still need to look at this calculation to see how many patients moved from hospital, B to the hospital A where the agreement is reached.
Yeah, okay.
But John, there is no, we can do a prospective adjustment under certain circumstances. There could be a prospective adjustment.
There could be, but you're not saying that, in a situation directed by an ACO or a medical group where they can show in advance that they're going to be moving, and on the back end that these cases did move. Is that something that would be acceptable?
It might be, but patients have a mind of their own, and they don't always do what their ACO doctors want them to do, and ACO doctors don't have any legal authority to decide which hospitals patients can attend.
Okay, and I understand that, and that's right. But I guess what I'm just saying is I understand, just looking at the volume side and the scenarios, but you will.
But if we have an HMO might be an example where an HMO has contracts with particular hospitals, and they are going to move cases, and they also have a legal authority to direct patients to particular hospitals. then I think that would be a clearer case of where we could potentially make an upfront adjustment. If there's a service line that's being closed at one hospital, then we could clearly and would clearly make a market share adjustment up front. If we have a service being moved inside of a healthcare system, then we would clearly make a market share adjustment up front. If we have a new hospital opening in part of Maryland and other hospitals are being impacted, then we would make a market share adjustment as soon as possible and not wait until the end of the year. And we might make some upfront depending on the situation. So that would be what we did with Germantown, for example. And
right. But
if we had a very large ACO organization and it had a large amount of patients and they were focused on making a massive movement of patients, I think it's possible for us to look at that as an upfront thing. If it's, we're going to put some of our ortho here and some of our cardiology there and some of our X there, it might be a little bit more difficult for us to do something that had kind of a miscellaneous referral pattern attached to it. And that's the best way I could describe the possibility that could come out of an ACO referral process that might not be quite as clean as some of the other situations. So, but I do think it would be possible to move based on an ACO or an HMO or some other type of entity or structure that's doing something up front, John.
Okay. All right. Thanks, Donna.
Thank you. Yes, David.
I know, Shula, you mentioned the work that you're doing on out-of-state hospitals, but I'm just curious if you could give us any indication of where you're going on, with like this example, if like we don't, I think on this chart we don't take into account if it's a border, if it's near a state border and we have people going into another state. Do you plan to count those numbers at all, or?
So we are planning to count them, especially for Medicare. It will be easier to count because we'll get the national claims. They are lagged a little bit, so that's one of the issues where we can put them in. And also we're exploring some hospital discharge databases from neighboring states. So eventually I think we're going to count it. It's just their timelines are not suitable to the way that just add the other hospitals here for neighboring states. And also I think one advantage is we can concentrate on the Maryland residents, for example, right? That will be a clear, the challenge here is we don't have a population for the hospital, so that's why we are doing zip code and service lines. But it is going to be easier, I think, to track the Maryland residents receiving services outside, how many of them are now receiving inside, and vice versa for the non-Maryland residents.
We do have contractual language for the D.C. border hospitals that are part of a system, that their system hospitals in D.C. are required to provide us baseline zip code data so that we can track changes in their utilization of Maryland residents. So there are, and so that accounts for several large D.C. hospitals.
You're referring to like Sibley as part of Hopkins?
Yes.
Okay.
And also the two MedStar facilities, Georgetown and Washington Hospital Center. So, and we have talked to Children's Hospital about providing their data, and they had preliminarily said they would be amenable to providing us their data so that we can track patients coming back and forth to children. There is a DC database, but it has some age on it by the time we get it, so it's not that helpful for what we're trying to do. But the Medicare database will be very current, and so it's like a couple months behind. So the western border, which has lots of border crossing, we should be able to get fairly current data. It's very heavy Medicare use in the western part of the state. On the eastern shore, same thing. So I think we could do a lot with the Medicare data. DC, we need a little bit more than just Medicare.
Right.
And the MHCC's, Maryland Healthcare Commission's all-payer database, or the private claims that they collect, their population is Maryland residents, so hopefully that will also provide us another data point to make that relationship.
So we can definitely track the private patients crossing into DC with the MHCC database.
I also thought Chris had some of the DC hospitals.
They're getting it. They're just starting to get the same data for DC that they have for Maryland now, so that they will have crisp IDs for all of the DC hospitals in terms of border crossing information. Now, we do have to have a data use agreement to be able to use that data in an appropriate way. So we can't automatically. There are some data use agreements already in place between Maryland and DC. Did actually already have some reciprocity. I don't understand all the details of that, but it is coming online now. So it is the potential to use that data just to look at raw numbers. It wouldn't be perfectly case mix adjusted, but you could get some raw numbers of changes in border crossing. Delaware is also coming into our data set, so we would have DC and Delaware in the not too distant future.
Donna, this is Ray.
Hi, Ray.
Question for you. Is that data delayed by some period of time? And I think it's appropriate to recognize it may not be perfect, and that it may not be the same services in the same, collected in the same fashion as they are in Maryland, having tried to use that data before. They use different DRGs, for example, and so on.
Right. When we look at Medicare data, they'll be using MS DRGs, so we would have to, do that more as a one-off analysis, at least initially.
So the formula, even though it makes sense from the utilization versus the market share shift, when we calculate it, so I'm now on the next slide, and there is a bigger printout of the table if you want to look at with the big numbers, even though still it's not that big, but I think it is a little bit better. So here I have in the last two columns the original formulas and the results. So for each hospital, so this is a particular zip code and a particular service line, let's say general surgery to go with. On the original formula, we calculate the changes in other hospitals compared to the hospital in question. So Holy Cross had 500 additional cases. So that's the column C. And then all other hospitals had only 25 case increases because you have other hospitals with an increasing ECMAD. So in this case, if we use the original formula, Holy Cross got 0 market share shift. And then down at the second group, so the table is grouped by the hospitals who are experiencing utilization increase and hospitals who are experiencing utilization decline. So the first hospital that had in the decline or no change is Sinai. So just for an example, I said, okay, Sinai had 0 change between the 2 years. Upper Chesapeake had 100 cases fewer in the measurement period. And then when you calculate the Upper Chesapeake numbers, since we have so much increase in the other hospitals, you see 625 cases for other hospitals. So with the formula, then what we are saying is, okay, Chesapeake, Upper Chesapeake is going to lose all those 100 cases because other hospitals increased by 625. When you do this calculation, what you would notice is that we took all the EC mass from the hospitals with the declining utilization, and we didn't give anything back to the hospitals with the increases because there are more than one hospital with the utilization increase. So when we did the totals using this formula, there were disconnect between what hospital was experiencing as utilization growth and how much they were receiving from the market share shift, because formula is not giving them more if they had other hospitals in the zip code that had an increasing utilization. So with the new one, what we are doing is, instead of looking at a hospital versus others, now we group the hospitals for increasing and declining hospitals and then do a similar calculation. So in this case, we compare the total decline, which is 129 cases, to the total increase, which is 654. And comparing those two, then we distribute the 129 declines to the hospitals who are increasing in their utilization in proportion. So you see on column D, Holy Cross had 76% of the increase for that zip code. So they get 76% of the 129 cases that we allocate for the market shift. So the concept is still the same. It's just the way we measure it differently. If you look at the zip total, it's 525 cases. But some of it is a utilization increase that we don't want to give out. So we just want to give out the market shift. So market shift would be 129 lost cases from declining hospitals.
This is Stan Doran. So this is all within the same zip code. Is that correct?
That's correct, Stan.
Okay, thanks.
And still for a particular service line. So the total still, should add up to, at the zip code level, at the service line, as you notice, the market share shift then is 0 because you take the declining utilization and distribute that to the increasing hospital. So at the end, the net effect is 0. And this, if they were reversed, then you'll do the same calculation.
So basically, this new formula balances. What happened in the old formula is that the HSCRC was taking away but not giving. And in the new formula, the takeaway and the give are the same. So as you might expect, when we started running the numbers on the old formula, we were taking away more market share adjustment than we were giving out. So this one corrects that issue and balances the take and the give.
Hey, Donna. This is Hank. Quick question for you. Can you hear me?
Yes, sir.
Thank you. I'm looking at this formula, and I know this is an example, but it does make you wonder what happened in the marketplace to cause general surgery to increase at 654 versus the decline of 129. Do you have any thoughts about how we should consider those kind of changes going forward? I can see where over a period of time that may ebb and flow and up and down, but at some point, if utilization has in fact increased in the market, is it expected that that increase that's singularly on the back of the hospitals in that market? There's certain things that you can't control, and I was wondering if you've given any thought to that yet. These use ratings.
I think we have given some thought to it, and maybe somebody else was going to answer that. I mean, one thought that we've given to it is to have different population adjustments so that areas of the state that are growing faster than other areas are getting more of an increase. So, you know, population adjustment should factor into that equation. You know, so that's one aspect. And so really what you're just saying is if there's a volume increase for any reason in any part of the state, are we thinking about at some point taking all the revenue for the state and re-swizzling it to the hospital that had the volume increase?
Or whatever. I'm looking at, you know, where this is all new to us in the hospital, you know, as you described it one time, is taking insurance risk. And we're new to it, and as use rates move, and they may move up and stay up, this is not me challenging. It's me thinking that over time we're going to learn a lot about use rate changes from quarter to quarter, year to year, and ever so often we'll get pops like this, and it makes you wonder if they stay at that, these use rates stay up. Is it expected that the hospital takes the full brunt of that? And I do appreciate your comment about population growth and refining that calculation as appropriate to try to identify more specifically the populations that are growing or aging. Anyway, you know, all of a sudden we find ourselves as insurance people, so to speak. So you want to look at these use rate increases and question whether or not they're in our full control, or if there's some other event taking place. I just wanted to make that comment.
There are some that are clearly not in the control of providers, such as births. That one's pretty clear that that's pretty separate from providers. We have, at least we hope, we have one situation right now that's partially in the control of providers and partially not. Say flu is an example, and so we are actually, you'll see at the commission meeting that the staff will discuss how we're monitoring the flu, and if we continue to see high utilization, that we might make adjustments to hospitals' budgets for the flu. Now, hospitals actually do have quite a bit of impact on flu by getting involved in vaccine programs. Now, this year the vaccines didn't work, but the hospitalization rate is 18% lower with flu vaccines, and so there's an enormous potential to reduce hospitalizations during flu seasons with high vaccination rates. So that one's partially under the control of healthcare providers eventually, but the fact that we have a CDC vaccine that didn't work, that's definitely not under the control of providers. So, you know, those are things that we can definitely adjust for. The other situations that you talk about are more difficult, and I think what we can't afford to do is to create a system that just makes volume adjustments 1 year in arrears, because then we really haven't stepped away toward trying to focus on a different approach. So
I agree, Donna, and I just wanted to highlight it because I think it could be something that could torment all of us, and I think once in a while, and we ought to just put it on the agenda, things that we need to develop a thought process about it. And I agree with you, some of it is in hospitals' control, and maybe some isn't, and not that I'm recommending what to do with it. I just want us to be mindful of it as it starts, if some of these things can occur. And again, we're in a startup mode, so maybe it'll dampen down as we go.
I think some of the aspects of evidence-based and per capita, when we start measuring some of those types of things, then we'll be able to take a little bit better look at some of the issues.
Yeah,
Right.
Michelle, I was going to ask something sort of similar to that, thinking that with this utilization increase in this example, what would be the drivers? Like population, which makes sense, and you know, that it may be something that we continue to look at how to refine, like transfers, for example, coming into this, and that may change a year-over-year look at what stays. You know, if it's originating from a zip code, but it's a transfer out, and then the next year the hospital has that service, and it's not a transfer, how we need to take that into account. So just, I was starting to kind of go down the path that Hank was going down, thinking just out loud a little bit.
So I'll just make a clarification. I inflated these numbers tremendously. If you think about it, we have more than 30 service lines and then hundreds and hundreds of zip codes. So these numbers, you know, if you are just looking at from a geographical perspective, utilization shifts from one year to the next is less concern. But overall, you know, the trend, we need to think about the more of a long-term utilization trends and how we are going to handle it. On the transfer cases, so let's say you had in the base year, you had a transfer, right, for that zip code. So you get a very minimum ECMAT because you just had a transfer case for that. And the hospital, in this case, let's say University of Maryland received that big transfer, that they have in the base a big ECMAT. In the next year, when the transferring hospital keeps that case, then you're going to see it in the market share as a gain for the sending hospital and a decline for the University of Maryland. Because the weights, since we are weights adjusted, you should have that in the market share gain.
And just that we think that will balance out, because that was when as I was looking at the decline, that then whatever moves up into this utilization increase, can you actually tease that apart and reconcile what is driving the increase, like a transfer or a population?
No.
Or is it important to even do that? I just, you know.
It's hard to say exactly what caused one to go down but you will. Part of the reason that you'll see a service line, let's just one service line that's going up statewide right now is orthopedics. So if a particular hospital goes down, it's usually not the use rate falling. It's if they lost market share to somebody else. And so this new formula actually recognizes that shift. And so we move the money to, from the declining hospitals to the increasing hospitals in that zip code for that service line. So that's really.
I think it's a start.
It's actually it's a good start. It's a pretty sophisticated start, actually.
Have we looked at the trends over the before 13? I mean, I guess in my head I'm trying to grapple with that all declines are market shift. Maybe they are utilization decreases, and Shady Grove could have been trending down years before, and so there's a legitimate trend down, not necessarily a market shift.
That's why we're trying to separate out the PQIs, because there we're actually expecting the volumes to go down and then readmissions.
Okay.
By separating out the medical service lines, that tends to have the same impact, because what you would see is that we tend to have decreasing medical utilization. So there's not so much shifting going on in the medical service categories for the most part, and the more of the shifting is going on in the surgery. If somebody has a decrease that's been going on in orthopedic surgery, it's really probably because they've been losing market share, because that's just not the way the service is going now with the aging population and the very we'll call it a very adequate supply of orthopedic surgeons in the state, possibly. That we have growth at that service line. So I think the best we can do to address that issue is the service line adjustments to try to separate out gaining versus losing types of things. We could put a few more things into the PQIs or the PAUs, if you will. You know, one of the things where there seems to be a little bumpiness, for example, is in sepsis. And we could take all of the sepsis and we could put it in with the PAUs so that we wouldn't shift revenue around when one hospital gains sepsis cases and another one loses them. You know, maybe that would, you know, there are a few more policy types of things that we could tackle and put into the PAUs, for example, to say, hey, we might not count it at sepsis as a PAU, but maybe we should not allow market share adjustments for growth in sepsis at one and decline at another, for example.
One of the things that I was thinking as you were talking about your examples of flu and then you were talking about orthopedic.
Sorry, and could you move it even closer, I think?
Yep. To differentiate what you were talking about with flu and with orthopedics, you've identified some things like with flu that could be very seasonal, good year, bad year, and I'm assuming then to be able to distinguish between utilization and market shifts, it goes up everywhere and then it goes down everywhere. On the orthopedics, you're identifying as a market shift, but I would also say that there could be even some other external components to that. For example, if we'd had a really bad ice event today, probably the slip and fall break a bone would have gone, and you would have seen orthopedic cases go up everywhere. And of course, we all know in hospitals that if you have a bad winter, your labor and delivery is going to be really busy in the next September.
Mm-hmm.
So I guess, yeah, and these are just they've stood the test of time.
Yeah.
And you can see that. So maybe one of the things to factor in is it market shift or is it utilization? Does it go up everywhere and then go down everywhere? Versus it shifts from one to the other.
Right, and that's what we're really trying to do with this formula is look at that, look at whether it's consistently going up or consistently going down. If it's consistently going down, we're not going to shift it. If it's consistently going up, we're not going to shift it. It's the inconsistencies that we're trying to adjust for. And we may have some things even to do with transfers. I really don't know until we see the data coming out of this flu season whether we had a lot of flu transfers out, into the academics. I just don't know whether we had severe cases being transferred out, but we'll see shortly. We can make adjustments as necessary. It's not a perfect world, but it's definitely a lot better than a high-level adjustment in terms of being sensitive to those factors.
Michelle, could you please, and get closer? Thank you.
The definition of your market that you're capturing is the definitions through the GBR contracts. So when you're looking at the market share for general surgery, for example, I mean, we typically think of a primary and a secondary service area. How are we defining it?
We moved away from just trying to define a primary service area. When you do at the zip code level, so your high numbers are in your primary service areas, but you didn't cut it. So if you have one case from one zip code, it's included, so that if you gain in that zip code substantial market share, still it's in your calculations.
Or maybe that would take into account transfers. That's what I was.
Yep.
Okay.
So we've done it as a virtual patient service area, but we will aggregate zip codes in some way in the non-urban areas so that we can reduce the number of small cells.
Okay. So I'm going to move to the value. So this is we are still very much focused on counting the cases with the formula. And the next question is the dollars associated with those cases. Well, how should we calculate the dollar impact of the market shift? And you could use different numbers, so we wanted to give, and these are by no means the only alternatives. I think there are other creative ways of doing it. The simplest approach is to use a statewide average cost per case and use that in the adjustment. And obviously, as we usually say, if it's simple, then usually it's not fair. So you could think about a hospital where maybe that's that's my phrase. So you could have a hospital that is very below the state average, and if they are losing cases, that they're going to be losing the revenue at a much higher rate. So it's not the fair portion for that hospital. If they are gaining, then they will be gaining more resources than what they would need. On the other hand, the statewide would make it revenue neutral for sure, because our cases are right now netted out. So you wouldn't worry about the charge differences between the hospitals who would be receiving positive adjustment and the negative adjustment. The second option is to use a hospital-specific average. And in this case, then you would worry about the imbalance between the positive and the negative adjustments. If in general, if a hospital has a high charge and if they are gaining market share, the net impact of the market share shift adjustment would be positive to the state, and we need to make an adjustment at the end. And here I said, sorry, a question? All right, so that was probably, if everyone can mute themselves, I think we are muting most people, but there might be some other issues with it. And in here, since we are case mix adjusting it, so that's adjustment already in the counts, should we consider other adjustments for the hospital specific in the reasonableness of charges? When we do the efficiency adjustments, we take out certain things out. Do we do some other adjustments here to try to get the hospital average charge to be specific enough for a cost of providing service to a hospital, but at the same time still trying to get them closer enough to each other, with excluding some of the charges from those payments. And the third one is there might be some differential calculation. So, the state was very simple. I'm already in a very complicated area. But you may use different numbers for positive and negative adjustments to make sure you have the revenue neutrality. So if this is kind of trying to move beyond using the hospital charge and awarding hospitals for providing additional savings to the system. So that's the kind of considerations on the hospital-specific charge. Alternatively, we could do a geographic-based charge calculations. So as you know, some geographies are more expensive than the others, regardless of which hospital they use. So we could calculate averages at the zip code levels, the way that we are doing the counts, and then reallocate the revenues accordingly. And at the end, I think whatever decision we make in terms of the charge, I think we need to make sure the adjustments are revenue neutral to the system, and predictable, so that we can find a way to finance the positive adjustments with the negative ones. So these are just our initial list and potential options for attaching the dollar values to the shifts that we will be calculating using the formula. So let me stop here and then see if you have any other considerations, or what should be the kind of the guiding principles in terms of thinking about this different options. Maybe simpler is the better. Well, I guess that's Kristen?
A clarifying question.
Yep.
So with the asymmetrical, or I'm sorry, with the hospital-specific one where we're looking at using the hospital-specific charges down or up, and it potentially comes out revenue neutral, you would then apply some smoothing factor over across all adjustments to then achieve the revenue neutrality, right?
Yep, that's one way of doing it. Yep. All right, so more to come. Yep. Stu?
So it seems to me having a hospital-specific adjusted charge approach and then going back and adjusting for overall revenue neutrality is equivalent, I think, to instead of counting the number of increase and decrease in the number of cases, you're counting the increase and decrease in dollars. And so one way to view that is to say if there's a decline in volume at a group of hospitals, that frees up a certain amount of revenue that then can be distributed to the hospitals that gain share. It's more sophisticated. I'm not sure what's fairer or not. I guess I would modify your, I think, very insightful motto by saying if it's more sophisticated than average, then we're not sure it's fairer, but it's more complicated. So I think, I mean, I would leave that to the hospital folks to kind of figure out what feels fair to them. I think there are different ways to approach it, but as long as we protect the overall budget neutrality, that makes sense.
I think the conversation about which approach to use gets into value, and it is a complicated conversation, and it might be something that we decide to start out one way with some kind of a migration toward another way, in terms of maybe you want to be a little more hospital-specific at the beginning, but then you're going to migrate more toward a geographic-based adjustment. The issue is if you have some hospitals with high charges taking cases away from hospitals with low charges, but of equal value or equal quality, we'll say for the moment, all of these things being very complicated to measure, then it may not be fair to necessarily, and I'm just going to make up a situation so we can get a situation. Well, let's say that hospitals in the city take cases from each other, and there's large hospitals in the city, like academic medical centers, that are more expensive. So we give them more money, and we take away less money from community hospitals in the city. But then we're trying to figure out how to balance that, and somehow we're balancing it out of the Montgomery County. That's probably, if we did that, it probably wouldn't be very popular. So we do whatever solution that we come up with in terms of balancing might, for the short term, simplicity might be good, but we might be having to deal with the facts and circumstances that actually occur when we start running the numbers here. So if we have a bad value result occurring by being simple, we might have to be a little more complicated. But for the first year, if we can have something a little simpler and it doesn't offend anybody's sense of value, it might be easier to do something simple than something complicated.
But the first principle, maybe principle isn't the right word, but the first requirement is overall budget neutrality, right? I mean, so you're not looking to encourage shifts in volume that go from low-cost hospitals to high-cost hospitals unless there's something explicitly gained from that, right?
Correct. So yes, so that would be accurate. So we would not be looking to, yes, drive cases from low-cost hospitals to high-cost hospitals unless something were special were being gained.
David Johnson?
Yes, I do want to complicate things a little bit more on the neutrality. And this is actually a very broad point, so I don't know if it really belongs in this part of the discussion. I wasn't sure where else to bring it up. On the subject of budget neutrality, for an individual employer, I've been thinking more about this, and I think, Shula, you and I have talked over the years about there's always that possibility for fluctuation throughout the year. And I'm really wondering for that, unfortunate employer who happens to hit this, whose employees happen to hit the system at the wrong time, for that, when in a situation where a hospital can charge a lot more for a case because their utilization is down or whatever, they could have there could be let me ask the question, could there be a significant variation in price for a given employer if one of their beneficiaries happens to go into the hospital when the hospital has the ability to charge a lot more? And should there be some level of protection for the for employers that their costs not vary over a certain percentage for a given type procedure within a year? And again, that's not specific to just the market adjustments. I'm just kind of an overall thought.
If an employer is large enough to be self-insured, I would think that they would have a fairly normal pattern of utilization across the course of the year. I mean, that's a supposition, but it shouldn't be really all over the place. The thing that employers grapple with, self-insured employers grapple with, that's even more difficult than the changes at a hospital might be extreme outliers, and so that's something that employers can reinsure. But extreme outliers would be more likely to cause variation in an employer situation than charge variation. But
it is a complicated issue, and I would say that there are certainly a lot of self-funded employers in Maryland that have 250 or 300 employees that are self-funded. So I think they could see pretty significant fluctuations throughout the year. I don't have the right answer. I'm just saying it's something, if there's any way you could at least be mindful of that, as you're thinking about how to make the adjustment. Because I'm just concerned that the employer sees something that, at the beginning of the year, a case might cost $3,000. Does it cost $7,000 at the end of the year, or vice versa? And so through nothing on their own, through no fault of their own, the employer sees very significant fluctuations in the cost.
Well, we do have 10% corridors on unit rate, so there is actually a limit on the unit rate changes. The hospitals are not allowed to overcharge their rates by more than 10%. So that's a fairly, I think that's a fairly tight, that's a reasonably tight range. We have an exception approach that we will enter into if a hospital needs to go above 10%. But in general, there's a focus on keeping that range within that 10% corridor.
And that's helpful, Don. I didn't realize there was that 10% cap.
Unit rate cap.
Okay.
Mm-hmm.
But in any case, this is a question. The employer should know before the employee goes to a particular hospital what that employer is going to have to pay for a particular case. Now,
we don't have DRG rates. We have, it's based on the underlying utilization for that particular
but
patient.
It's not retroactively adjusted, is it, or is it?
No.
So you know what price you have to pay for a particular hospital, right?
Well, you would be hard pressed to figure out exactly how much you were going to pay because it's based on the units that particular patient uses. So it's not based on the.
But the price per unit is
the price per unit is you can see what the hospital charged last month per unit, but to take what units are going to be used for a particular case would be a difficult undertaking.
And how would it be affected by the market share adjustment then?
It wouldn't be affected at all.
Oh, right. Okay, that's what I was.
I thought you just drifted into kind of another topic. It wasn't really related to market share adjustment, but it was fine.
You're correct. I wasn't sure where to insert that point, so I just dropped it in here because we were talking about budget neutrality. But I think you've addressed it, Donna, with a 10% corridor, which I did not realize existed. So that's helpful. Or 10%.
Yep.
No term. Yeah.
Rate compliance. So there's unit rates. There's very detailed unit rates, and there's a 5% compliance range on those rates, which can be raised to 10 with permission.
And that all stays in place.
That's staying in place during the year. And then at the end of the year, we have market share adjustments, and that would be put into a prospective set of rates.
And I added this one, in addition to what average we use, the next question is the variable cost factor. So if this is an additional volume for the hospitals, the policy from the charge per case system was 50% variable cost factor, and we use it as symmetrical, meaning both the positive and negative adjustments are done at the 50%. We need to think about whether are there other alternatives when we do the market share adjustment. And here I would like to just give us a caution, because I think our whole model is about utilization control and getting the unplanned, unnecessary system out. That's where our incentives are focused and where the money should be. And when we do the market share adjustments, the balance between the larger incentive and the market share has to be taken into account. If you make the market share, I was actually driving here, and I'm like, well, if I were a CFO, what would I do? Like, you don't want to give too much incentive or higher incentives for market share shifts than the other incentives that are going to make us successful in the system, because nothing is going to change. As Donna said, we don't want the system to be doing a shift adjustments 1 year, after the fact. So that's why I wanted to put that in for our discussion. And the last but not the least aspect of the policy is, when do we do the shift adjustments? As John pointed out, there might be situations where we need to make these adjustments prospectively, and we can define those as we go along. But in general, I think for the general calculations, we are envisioning to make these on an annual basis. And for 16, since 14 budgets were done, we would have only July to December 6-month period to look at. And then for fiscal year 2017, then we will have the full 12-month period to do the adjustments. And this takes into account the data lags and the things that we need to do, so we have a number in hand come July.
So just so I'm clear, so the calculation for FY16 is based on July to December 14 versus July to December 13?
Correct.
Okay.
Yep.
So we're moving the market share calculation to a calendar year. Is that what we're trying to accomplish here, looking at it on a calendar year basis and then making an adjustment to the fiscal year after? Okay.
That's what we're suggesting, but we'll hear suggestions, and if that, it's when you start thinking about the data processing and settlements, and I know everybody always likes up-to-the-date last minute, but it would be hard to have a rate settlement on July 1 if you didn't cut it off at the calendar year.
Okay.
When you run your first round of studies, what percent, how sensitive is this market share shift going to be? One of the thoughts here, by doing a calendar year, you are giving hospitals a certain amount of time to look at the data, understand it, figure it out, but then also adjust if it's a very sensitive indicator and moves revenue in a, like even a 0.5 percentage point on several $100 million of revenue is a large amount. So, giving time to adjust for their own operating budgets, which typically begin July 1st, I think is a good idea. I think the timing is good. But I'm just curious, in all of our levers that we have that make up our revenues, is this going to be something that's very sensitive and a small change is going to yield a lot of dollars or not? I don't know if you have a sense of that yet, but it might just be something as you model it to figure out.
Mm-hmm. Yeah, good point. Just one thing I noticed, running just one quarter data, you have, since it's at the zip code level, you may not get the adjustments because it takes time for the pluses and minuses to show up at the zip code level. So that's one thing I noticed looking at that one. But definitely we are looking at how the small cell sizes will impact.
If it is a sensitive indicator, then hospitals, the sooner they know that, the better they're able to adjust whatever else they have to do to balance under GBR in their budgeting process.
Which would argue for the January 1 date so that people could bake it into their budget and do what they need to do to get it, the calendar year lets people deal with it from a budgetary standpoint in advance. But, there are some extreme situations as well that have to be handled.
All right, so that's so the next steps are we are reproducing the data files to share with the subgroup to go into detail, and we'll get back to you in the next meeting about our progress on it. Right now,
and I will turn the baton over to David.
The next topic is the sort of the kickoff of trying to come up with a balanced update for 2016. I'm going to start out just with the goals to guide payment policy that this group came up with last year, promoting the three-part aim, meeting the all-payer model requirements, providing hospitals with overall fair and reasonable compensation, providing rates and revenues that are sufficient for efficient and effectively operated hospitals, and promoting health equity. Those were the payment policies from last year. I don't know if there's any comments on those or feel comfortable with that. Okay. And then there were some desirable features of the payment policies. There were a number of them that were summarized into these 4 categories. Again, that came out of this group. I don't know if you have any comments or new thoughts on these. We thought they were adequate to kind of guide the process again this year. Okay, and then some more specific key considerations as we get into 16. First, compliance with the all-payer and Medicare guardrails. Secondly, expected growth in Medicare hospital rates, inflation, population demographic adjustments, financial condition of the hospitals, uncompensated care and the impact of the Affordable Care Act expansion, infrastructure adjustments, shared savings, the Holy Cross Germantown Hospital opening that was built into the rates for the current year, but only for a partial year, so we need to make some sort of adjustment to capture the full year. And then changes to the MHIP Medicaid assessments. Again, the MHIP assessment actually changed a quarter of the way into the current year, so again, there's got to be some sort of adjustment to annualize that. And depending on what the governor does in the incoming budget, the Medicaid assessment could change as well. And then some other considerations that we're aware of are how to deal with categoricals and how to deal with transfers. So that's sort of the issues that we saw sort of driving the discussion as we go forward.
David, this is Brett. Just a couple questions about these considerations for 16. I know you, and this is a very subtle one, you have it written there in the second bullet, expected growth in Medicare hospital rates. You know, I think we would want to distinguish between what we're talking rate increases versus overall payment increases, you know, with the test being, you know, per beneficiary. So I'm assuming that's hospital payments versus hospital rates. Right. I think the other, as we think about that, and I'm not sure where these all fit in here, but just a few other points to bring up. One, whether it's under population and demographics or it's someplace else, is when we talk about, you know, hospital payments, we're right there, we're just talking about the numerator. So I guess the question is to look at, you know, both the on an all-payer, you know, per capita basis. So what's the overall population growth, and then the Medicare, you know, the growth in Medicare beneficiaries to understand how much of that payment is driven by potential change in denominator. If we're seeing, you know, changes in beneficiaries, you know, growing at a more rapid pace here in Maryland, whether that's aging or migration or whatever that may be, to drive some of those payments. Just, I guess, two other points as we start to think about this. One, and I'm not sure if this falls under shared savings or not, but you know, how we handle the, I guess, the temporary or the one-time nature of the pay performance adjustments and how they move in or out every year with, you know, shared savings for as compared to the Medicare programs, but how those change on a sort of a rolling one-time basis, if you will. And then the last piece, you know, just as we move forward, as we've completed year one and we talk about shared savings, but some consideration of, you know, we still haven't landed on a policy for underages or overages from targets. And as we think about that, you know, and certainly that's a point of discussion right now, but you know, how does that fall into the 2016 process?
Any other comments? All right. For those of you who don't come to the commission meetings, we also just wanted to give you a sort of an update on the performance so far this calendar year. This revenues through October on the all-payer per capita guardrail, which caps growth at 3.58%. We've seen growth of a little bit under 2% for the year, so doing well on that target. And then on the Medicare fee-for-service cost per beneficiary, preliminary data we have shows that we are beating or doing better than the nation in terms of growth being slower than the nation thus far in calendar 14. So far, so good on the two tabs. All right, so.
And just to point out on the all-payer test, it would have been very difficult not to do well on that test after we took out the uncompensated care adjustments at the beginning of the year, which, you know, we intended to take out, and we did. So that makes it pretty hard to not do well on that test this year.
Okay, so this doesn't show up very well on the screen, so I will walk through this in great detail so you don't hurt your eyes. So this is sort of the standard sheet we've created in prior years to sort of walk through the adjustments. We've tried to fill in the pieces that we have at least some preliminary data on. It's not a completely filled in list. So at the top, we just look at the maximum allowed growth. So we have the 3.58 per capita guardrail that we start with there, and then a population growth estimate for the coming year, which is a little under 0.6%, based on the most recent data from the Maryland Department of Planning. So those combine to about a 4.17% maximum allowed growth.
The population numbers just ticked down. The population growth numbers have been ticking down just a little bit in the DSP data. That's like 0.1% down.
The next section looks at the components of the revenue change. First piece is inflation policy adjustments. As in past years, it used to be Global Insights, I think it's now IHS, that they are calculations of the market basket. We take 91% of their kind of core market basket, which so far is growing at 2.9% for the upcoming year. And then there's a capital component, which accounts for about 9% of this. It's growing at only about 1.5%. We will have new data probably in mid-February from them, so this number will change depending on what they put out. But for now, that's the preliminary number we have. In terms of adjustments for volume, the volume is in last year was adjusted net of potentially avoidable utilization. So the maximum, given that we're seeing population growth of a little over 0.5%, would be that 0.5%. I lumped some other things here that may or may not really be appropriate to put under volume, but other issues that we need to look at, as I mentioned earlier, are transfers and what impact that has on rates, and any additional funding for the categorical, and then any net impact of market share adjustments. And these are all things that we need to sort through still, so we're not putting any figures at this point, but we'll continue.
And we did consider them last year when we set the limit on the population adjustment, that there would be some of that money taken up by the growth in categoricals. And we'll see. Right now, we're talking about a $5 million limit on the transfer. So just trying to think about how that would affect 0.57, so that the 0.57 has to cover, those sources of volume growth if we didn't have a revenue neutral market share adjustment. Or transfers, and categoricals by their nature will not be revenue neutral.
Sure. Just two quick questions on that. So the 0.57, is that similar to last year's estimate where everybody had the age-weighted population adjustment by hospital, net of so that's net of PAU, a PAU reduction there?
PAU and so we had the scaling at the end after the PAU.
Okay.
So that was the net number there. And thinking about the demographic adjustment now and the discussion, it's kind of, we are still discussing with the CMMI on our aggregate amount for quality-based programs, and it seems harder for outsiders to think about our PAU adjustment as a risk and efficiency adjustment. So, we may want to think about making it more easy to understand, or kind of on the quality bucket more so on the demographic bucket. So there might be slight changes that we may think about so that it becomes more apparent that all hospitals have a reduction for the PQIs and the PAUs.
We may or may not be able to accomplish that this year for a variety of reasons. So that would, our ultimate goal would be to try to make that a more explicit adjustment, but it may not be ready for prime time this year.
More explicit adjustment, in that there would be a direct adjustment to the annual payment update as an incentive to reduce PAU?
Yes.
Okay.
Similar to the readmission adjustment,
sure.
But broadening it to incorporate the PAUs, and in that case, pulling it out of the population adjustment possibly, and making it an explicit adjustment similar to the readmission adjustment. We're not there yet, and I think there's a number of factors that will keep that from happening this year. One of the biggest factors is being able to adjust for things like socioeconomic status, et cetera. We're not quite ready to move forward to be able to do it in a scaling manner, if you will. So that's one of the reasons why it might take another year to get there.
And I would also argue, not that we need to, but as we look at the demographic adjustment, with what we have in there for PAU now, and the fact that we are applying a 50% variable cost factor to that, I think we would want to consider those things if we're talking about a direct incentive to reduce PAU as well.
Right. So we're just, we're still in a transition stage of how to best address PAUs. The other reason for not doing something dramatic this year is that it appears that we need to continue to do something more dramatic with readmissions because they are have not gotten down as far as we want them to yet. So I think if we started moving other types of avoidable volumes into the calculation right now, it might confuse folks. So I think it's better, probably for this year to stay focused on the readmissions and keep the more minor, the more minor adjustment, if you will, linked to the PAUs.
Just the other quick question then, and I see you, and I think you said it, you have market share adjustments here. So we would only need a market share adjustment in the context of the update if we ran the market share policy and decided that you didn't want to make it revenue neutral in the context of the policy and you wanted to make an annual payment update adjustment for that, correct?
Correct. So ideally it would be zero impact. Or if we continued with our old formula where we were taking but not giving, it could have actually provided capacity. But we've changed that formula.
Yeah, moving down the chart, this past year there was infrastructure allowance provided. We don't have a number in there at this point, but that's certainly a discussion topic, particularly maybe around regional collaboration, something that there's an interest in. Below that, certificate of need adjustments. This is the Germantown Hospital figure. We need to do some additional calculations, but there'll be some sort of annualization of the hospital's opening. Then we have sort of a subtotal there of 3.35%, but obviously there's a number of blanks that will impact what that number ultimately looks like. Some other.
Sorry, before you go on to the next group, can I just go back 1 minute to the regional collaboration?
Mm-hmm.
Are we talking about the BRFA funding there? Or?
Not necessarily. I mean, I think there's been some discussion at the commission meeting. We haven't gotten deeply into the discussion, but actually about providing some, we'll call it positive incentive money for regional collaborations to really focus on developing infrastructure that's patient-centered infrastructure to tackle high need patients and to tackle chronic conditions and to try to do that in a collaborative, patient-centered way. So there's been some discussion about devoting funds in the update process to that effort and making it focus on collaborative approaches.
Okay. So similar kind of idea. I mean, the concepts behind it being regional, being about care improvement, collaboration, those are similar to the thoughts behind what was envisioned with the BRFA, but this would be just
to take it forward. So if the BRFA could accomplish one level, then you might actually need to have some, funding sources for the infrastructure on an ongoing basis, or at least getting started. So that's really to say, hey, well, maybe we need to have some case managers, and maybe there's some things that are funded out of the new Medicare community or the chronic care improvement code for the doctors, and they can provide some funding for chronic care improvement, and the hospitals can provide some funding, and so that it's really kind of really an opportunity to begin starting to talk about that process. We do have a draft that we need to start sharing with folks of an RFP process to get collaboratives to submit proposals to get some BRFA planning money and get the planning of these processes started. And then we may need to, we need to think through how they would operate on an ongoing basis. So I think it's an important topic, and thank you for circling back.
Okay, thank you.
The next section has a few other potential adjustments. First, set aside for unknown adjustments. This past year, there was a 0.5% set aside as sort of a contingency to make adjustments during the year. We left that blank for the moment, but there may be a need to do that again. Reversing the prior year's shared savings reduction, so you're adding back the money that was taken out the prior year. Potential that there will be some readmission positive incentives that will have a small impact, and then the shared savings negative scaling adjustments for the coming year. So those have, essentially they almost wash out. It's a very slight negative impact to those three items. And so at this point in the calculation, the per capita is at about 2.71%, so within the 3.58 guideline. There's some components of revenue change that aren't really hospital generated that also are going to have an impact. The first is uncompensated care, and we're going to start talking about that more in a moment. We do expect some sort of negative impact from the uncompensated care as a result of the Affordable Care Act expansion, adding more people to the insured side. There may need to be an adjustment for Medicaid expansion. One of the issues that we're investigating is whether the Affordable Care Act expansion group is actually utilizing more hospital care than they did prior to having insurance, and whether there needs to be some adjustment to rates to capture that. There's also the issue of whether that's a sort of one-time uptick in utilization as people suddenly have insurance and get some care they needed, and then it'll level out. So we need to investigate all that further. The HIP adjustment, as I mentioned before, we need to make some adjustments to annualize what was done last year for part of the year, and then just sort of a placeholder for any other assessment of changes that come out of the governor's budget and legislative session. So that's sort of where we are now. Yet the bottom line is a per capita growth of just under 2%, but there's lots of blanks here, so that's, no one should hold on to that number as a firm number at this point.
And before those negatives, it's 2.71 before, without filling in all the blanks, but we're just starting to try to see how the blanks are going to look. We begin to fill them in.
So Donna, this is Raymond. What happens if we don't meet the readmission targets? Where does that fall into this calculation?
For that, we put in a placeholder. We don't really know what the answer to that question is, but we put in a placeholder of 0.15% increase, assuming that I think half of the hospitals would make the target. And if all the hospitals make the target, then I think it's a 0.3% increase.
And we'll know the final numbers by April, towards the end of April, for all the quality programs. But since they were on a calendar year basis, we're hoping to have the final calculations by that time.
I know you're just starting to think about this issue about the uptick in, I guess you said, from utilization of Medicaid enrollees who...
Sorry, Tricia, could you move it closer?
The uptick in the Medicaid expenses for individuals who, I guess, weren't insured. Is that what you're kind of looking at? I mean, I'm not quite sure why it's just a Medicaid issue. Obviously, we've always assumed that uncompensated care isn't the true utilization of what someone is like when they're insured. So whatever we're looking at should be a broader analysis, not just Medicaid. It should be people who are insured versus not insured. And I guess I'm a little bit confused in terms of the methodology. I mean, they are from an uninsured perspective, but from a Medicaid enrollee, I mean, their expenses aren't surprising us, and they're actually a little bit healthier than our previous PAC enrollees, a little bit. But so
obviously this doesn't surprise us. So I'm not quite sure how, when you set global budget, when you look at Medicaid, I would assume you would have thought that Medicare market share for Medicaid would have gone up. I mean, we took on probably the largest expansion in history in a long time. So I would have thought that the formula for global budgets would have taken that into consideration.
No, we did not put any upfront use rate increases in global budgets. We said that we would do that on the back end.
But I guess what I'm saying with some of the use rates, I mean, they aren't different than what than our disabled group. I mean, they're when you compare them, it's not like they're complete total outliers. They are when you look at from our traditional parent population, but I mean, we serve some very sick individuals in there. So in terms of a mix, when you're looking at Medicaid, I guess
they're not necessarily higher cost than existing Medicaid population. So when we baked in the budget, we didn't bake them in at a higher Medicaid cost. We baked them in at their self-pay utilization. So we did not assume that there would be any use rate increase at all. We said in building the hospital global budgets, you will have no expansion in your cost from Medicaid, from the enrollment. It will not create an expansion in the cost of the hospital. That's what the assumption was going into the global budget. There would be no increase. So now what we're trying to do is to measure, was there some increase for individuals who enrolled, and if there is an increase, was it temporary or permanent, which that'll have to unfold over a little bit of time. Most of the studies that we've looked at show that a lot of it's temporary increase, but we're not 100% sure of that yet. Some of the early data is suggesting that it might be temporary. For example, orthopedic surgery went up for Medicaid patients, so people who couldn't get a doctor to see them get Medicaid. They get the doctor to see them, in the third quarter of the year. The first 6 months they get worked up. The third quarter they get operated on, and so that example, that might go back down. There's some emergency room increase, and that may or may not go back down. So, for example, we're actually looking at it based on patient ID. So we're going back, taking patient IDs and going back into history to see what happened to that patient last year. So before they were enrolled, what was their utilization pattern in the prior year? And so we can actually do it on a very particular patient-level data. And that's how most of the researchers have tried to, who've looked at pre and post, have tried to look at it.
I mean, I get it from an uncompensated care. When you're uninsured, you use healthcare services at a less rate. I get that piece of it. What I don't understand is, I mean, I would assume that you would know that the Medicaid population was going to grow in the last year, but in terms of a ratio, in terms of cost, they're not significantly increasing the Medicaid population and the cost per enrollee.
Right, it's not a Medicaid trend, it's a use rate trend only. It's not really something to lay on top of the Medicaid program per se. It's really just to say, if we had patients last year that had a use rate of 100 per thousand, and now we have some people who were uninsured who had a 0 use rate. Now they have insurance, and now our use rate is 101 per thousand just because we gave them insurance. Now they have access to services that they didn't have access to before, and so they're using them. And so we did not bake that into the budget of the hospitals when we set the rates. So we're trying to, we did build a clause into the global budget agreements for every hospital in the state that we would look to see if there were any utilization increases coming from the enrollment, because we didn't expect hospitals to take on that risk. They didn't know what the risk would be. We didn't know what the risk would be, so we did not. We assumed that there would be no increase. So right now we can see that there actually is some increase, and it is lower than the increase in utilization is lower than the decrease in uncompensated care. I know that's pretty complicated stuff, but
I mean, I get it. I guess I'm just a little bit surprised that there wasn't more flexibility built in when use cases would have gone up. I mean, we sort of assumed. I mean, we were pretty. Our enrollment estimates exceeded them, but we knew they were going to increase. So, and we knew pretty closely what this population was going to be like. So I would assume that it would have been built in.
We definitely did not build any uptick in the budgets. And we actually did literature searches, and an awful lot of the literature searches told us that there wasn't an uptick in hospital, that there was a lot of uptick in doctor visits, but not so much in hospital visits. So we were expecting to see a big increase in doctor visits, but not so much on the hospital side. So now we're, honestly, we'll have one of the most interesting data sets in the whole country, because there's nobody else who actually has the kind of data, I don't think, that's really linked up at the patient level, that we can actually pop out the results and look at it and see it pretty fast, and look at it over time.
So will you be able to see whether or not the increase is coming in elective surgeries?
Yes, and I can say for sure that the biggest increase is coming in orthopedic surgery right now.
And just and we are looking at the Medicaid because that's the highest increase in the enrollment. When you think about the exchange, not a lot of people enrolled, and even if they are enrolled, some of them came from an existing insurance policy already. So we think the impact of the private exchange is probably minimum, and eventually we'll get there. But we thought the Medicaid will be the, place to start as the biggest impact.
Are those I'm sorry.
I mean, I think it's broader than Medicaid.
It is broader than Medicaid. It's tougher to get the enrollment IDs for the exchange population, and then to find out which of them actually didn't have insurance in the previous year. A lot of them are actually coming from existing individual products, because all of the individuals had their insurance canceled, and this year those who didn't have it canceled last year were 100% canceled this year. So Maryland actually had a fairly robust individual market before the reform. We had, I think, 250,000 people enrolled in individual products. So all of those folks are being pushed into the exchange. I'm not trying to say that in a with a negative tone to it. And then there are also individuals floating in between small group and individual based on optimization, particularly with small groups in the size of 2 to 4 are looking at exchange as possible places to get better prices and subsidies. So there's a lot of movement going on that makes it kind of, even if we had the IDs, which we don't at this moment, makes it a little tougher. Commercial utilization is dropping in the state. We don't have enrollment to go with that, but the actual commercial use is down.
on the expansion trends, whether it's Medicaid or other insurance, is that something? Are you going to bring those summary trends back to this group or someplace else to have that to look at those trends?
Yeah, we hope to have a great deal of data for the next meeting, the early February meeting in this group, to walk you all through.
Can I ask, this came up some meetings ago, and I'm sorry to not remember, will any of this data include, or do you have merged yet with the Healthcare Commission, outpatient visits? For instance, when we look at not just the Medicaid population exchange, everybody here knows I represent a lot of physicians who are very worried about the just recent round of reductions in the rates for the evaluation and management codes, where they were 100% of Medicare and they went to 87. So we look at, the providers that are going to be available to see those patients to hopefully keep them out of the hospitals, and are they going to continue to be there, if those rates, stay low. Anyway, I know somebody's the Health Commission here is, but is that happening in any case? I mean, it's amazing that you're able, on the hospital side, to look at these Medicaid patients and see what their utilization was prior to them being, when they were uninsured. I mean, you're looking at an individual when they were uninsured and then now they're eligible for Medicaid and what their utilization is. I'm just asking, is there anything happening also to merge that outpatient side in the data?
We aren't doing it right now. I mean, not now. It's not. We don't have the data. MHCC has the data. We're the state, so it's not. That's the left arm and the right arm, but it's not. It's not that we. The data is there, but we're not. The HSCRC isn't using it right this second. We have plans to use it, but we're not using it right this second.
Yeah, and I guess, and this is not so germane to this, but it does have an impact on the hospital utilization and costs at some point, certainly at some level. That's why I raised the question. Thank you.
It also somewhat ties in when we're trying to look at savings over time on the waiver to the Medicaid population. I mean, the current analysis that we worked on, it removes anyone who's at 100% federal dollars. But what you're telling me is that even though there's this growth, we've removed it from the savings calculation, but in terms of looking at use rates and compensation, we're not going to see the same level of reduction in uncompensated care because the use rates weren't included in it. So
we're going to see a full reduction in uncompensated care. So if there's a reduction of X in uncompensated care, we're going to make that X reduction going forward on July 1.
But there's going to be a subsequent increase.
There might be some utilization increase, whether it's temporary or not. We have to at 50 cents on the dollar for it, 50% variable. So if there's a Medicaid growth and in utilization, then we would be providing at a variable cost ratio for a volume growth, not at a full 100 cents on the dollar, but at a 50 cents on the dollar for a volume growth that was occurring from. So we might provide that. We have to look at it some more to see whether it looks like temporary or permanent, and try to make some value judgments about that.
So in other words, whether or not it's going to look like a bad flu year just once, and then next year may come down. A bad orthopedic, you're getting say the elective orthopedic case is done this year, but then that volume will go down for next year.
Right. That would be the thing that we would be trying to get a grip on.
So to a certain extent, like the flu, you'd expect that volume increase to kind of go up in areas where the population, this particular population, was heavy. everybody, with every hospital?
Well, it's you know, we haven't really gotten final data in yet, but just some of the preliminary data that we're looking at actually shows, and we haven't really finished analyzing it. We don't know how it'll pan out at the end, but it looks like the PAC enrollees don't have as much of an increase as some of the other new enrollees, which is kind of to be expected because the PAC patients have been managed by the MCOs now for their emergency room care for some time. And also the MCOs knew who they were going to be well before the beginning of the year, so they could put management systems in place for their hospital utilization. So far, which again, we're early into it and we could find a data error that would turn our thinking around, but so far it doesn't look like the PAC enrollees had much utilization expansion in the hospitals at all. And some of the other folks who were kind of new to the program have a higher utilization expansion. But as Trish said, they're lower cost enrollees to start out with. They're a healthier population. They're more similar to a commercial population of patients than to the PAC population, who are very high utilizers. So we're just getting our arms around it now, but that's what it looks like, so it might not be evenly distributed all over the place. The PAC population is not evenly distributed. The new enrollment population might be more evenly distributed around the state than the PAC population was. It was very concentrated. Just early snippets of data analysis.
So we'll have some real data to put in front of you at the next meeting, which maybe will help to focus the discussion a little. That's really all on the balanced update, unless anyone else had questions or comments. The last topic of the day was uncompensated care. As I said, at the next meeting, we're going to present a lot of the data, some of which has already been talked about. So the focus today was really just on some general methodology issues looking toward fiscal 16. The slide up on the screen just shows you the uncompensated care policy for the current fiscal year, where the basics is that we made we used a regression model to help develop what we thought the underlying UCC rate would be, which we came up with 7.23%. And then there was sort of a deduct from that made to capture the expected impact of the PAC population being fully covered through Medicaid, so that they would have hospital coverage, and that would reduce uncompensated care. And that PAC adjustment was equal to a little more than 1%, 1.09%. So the uncompensated care rates built into the current year are about 6.14%. So it's kind of what we expected, and then adjusted for the PAC. Next slide, just going forward, the question is whether we should, again, do a regression and analyze all the variables that might impact the uncompensated care, or just use that 7.23 kind of base percent that was calculated this past year doing the regression, and then replace the PAC adjustment of 1.09% with a new adjustment that takes into account not just the PAC population, but all the other folks who are obtained coverage through Medicaid and other parts of the Affordable Care Act. I think we're at this point leaning toward doing that, not redoing the regression, just using last year's regression and then trying to make a kind of a global adjustment for the impact of the Affordable Care Act. And the reasons for that are that the ACA has really changed the mix of people in self-pay and in Medicaid, and these are dramatic shifts, and trying to update and choose variables that really are effective at predicting when we're in the middle of this sort of major sea change seems like, kind of putting a finger in the wind and trying to guess. And you can certainly do a mathematical calculation, but how valid is it?
And you can't do it over a 3-year period. The problem is that we used the Medicaid inpatient admissions as one of the variables, well, now that would be a very poor variable in predicting, when we get to the new data, that really takes on an entirely new character with the new data. So we don't think that you can take 3 years worth of data and use the same formula for 3 years like we have in the past. So this is at least our current thinking in terms of moving the process forward is to use last year's results and then adjust them for the changes.
And as David said, I mean, you can run any regression you want. You can put any variables you want, and you can try to make sense of it. But at the end of the day, conceptually, if you think about it, with the drastic changes happening, it is not suitable to do a regression analysis with the data, unless we use the most recent data and then try to come up with a new model, but then we don't have enough data points to do it.
Any comments on that?
Is there any thought, David, to look at additional factors such as the change, as you said, we're going to a lot of high deductible plans, and that may be increasing the pressure on collection activities at the hospital. So here there has been a reduction in bad debts and charity. I'm not debating that. And there has been more coverage provided through Medicaid. But then there's also the move towards high deductibles. And in the commercial population, this may be having a little bit of another negative impact.
Well, we could try to look at that, but we're actually thinking that it's possible that things could have drifted in the other direction, because basically we've drifted to higher percentage of the revenue being under Medicaid, and Medicaid has 0 deductibles and copays. So the collection quality, if you will, has, from that point of view, has actually improved. Now, I know that you all will tell me immediately that there's a lot of denials on Medicaid, and we can't deny that. But the collection quality, I believe, from the fact that we've actually increased the government share of the patients in Maryland, overall will have improved, because of there's actually a lowering of deductibles and coinsurance when we have more Medicare and Medicaid revenue. And with the increase with more Medicare beneficiaries and more Medicaid beneficiaries, then even though we might have some uptick in some employers having higher deductibles, it doesn't appear, on the surface, without getting further into it, that will tend to have that unfavorable impact this year. But it's something that we are willing to look at. We've begun to collect the bad debt data. We can start looking at the bad debt write-offs by payer. And we won't have a trend line yet, but we do actually have that data coming in, and we're extremely pleased at having that and some of the things that we can learn from it relative to that topic.
Hey, Donna, just a process clarification. So the patients who have switched to high deductible plans as of January 2014 timeframe, their copays and deductibles probably wouldn't be written off for a minimum of, I don't know what every hospital's policy is, but ours is 120 days after it hits the self-pay. So once the claim is adjudicated, 15 to 45 days, depending on the payer, then the balance rolls to self-pay, and then there will be another 120 days at a minimum before it's written off. So that puts you in the third quarter, fourth quarter of the year before you're going to see any write-offs related to that.
Well, that isn't a new trend. I mean, this is a continuing trend of switching to deductibles and higher deductibles and coinsurance. I guess what I'm my reasoned hypothesis is that the number of commercial enrollees declined, and so that actually decreased the exposure to deductibles and self-pay, deductibles and coinsurance, because Medicaid has none, neither. So we're open to continuing to look at it if there are some ways to, think about it,
right,
that we can utilize. So we're not against thinking about it.
No, I just
and
we're not timing in the data.
Right, we're not against incorporating it into some calculations, but
okay.
And certainly on that point, whether that a hypothesis bears out or not, we still have the timing difference. I would say the timing of getting folks, even with the expansion, the Medicaid expansion, enrolled in coverage. I think we've clarified within the data that Medicaid pending should be treated as Medicaid, but I do think there's even still some lag as we'll see that come through in the financial statements as we get folks qualified, and same type of thing as we talk about actually getting those folks there and getting that money collected.
And I just wanted to add, I think it is a good thing to monitor, and I think the commercial population will continue to see higher out-of-pocket costs for beneficiaries. Particularly, I think employers are more scared now than ever about the 2018 excise tax on high-cost health plans. I think a lot of employers that held off in the past, really significantly increasing out-of-pocket costs. Just the buzz that I'm hearing is in 2015 and certainly in 2016, they're going to look a lot more to passing on absolutely as much as they possibly can because of their fear of to pass off to the employees, meaning higher out-of-pocket costs for employees, because of the concerns over the 2018 excise tax. So something to continue to monitor.
Yeah, for sure. And I just on that front, as a chuckle, I was noticing that Harvard just increased their employee contributions and their deductibles and coinsurance, and these are the folks who brought us the design for the exchange, and their faculty were having a fit about having to pay all that extra money. So what's good for the goose is good for the gander. So I was very pleased to see our policy developers having the same deductibles and coinsurance. They're still lower than the exchange enrollees, but it did create quite a firestorm, so I got a good chuckle out of it.
Maybe they figured it was so complicated that even the Harvard faculty couldn't figure it out.
So they figured it out. They figured it out. They were trying to prove that it didn't help with use rates and that it was a pay cut. And they said, hey, folks, welcome to the club. It is a pay cut. That's how it works. Welcome to the club. Oh, hey, what were you thinking about when you did those policies?
And I would also just think, too, that hospitals would have some way to put in place, and probably already do, and I know they already do, to mitigate some of the risk of loss on the deductibles, especially if you're getting in elective admissions and elective surgeries. You begin to work out a payment plan with the patient ahead of time as to how that deductible or that coinsurance is going to be paid before you take them in the front door.
Yes, and I think the collection policies, by getting some of the data in from the hospitals where we can actually start looking at that by payer, we can hopefully help point hospitals to adequate collection policies. We do have charity requirements in the state of Maryland, and so those still have to be, you have to abide by those, and you have to provide access with those charity policies.
Okay. The last slide is just the next step. As I said, we're going to present some data at the next meeting. We're hoping to show you some data on calendar year 13 and 14 self-pay and charity utilization. We've actually shared some of this data with individual hospitals to do some checking of the the numbers, also some data on Medicaid charges, and then we're working with Chris to be able to show you what the prior utilization of some of the new Medicaid expansion folks was. So we can kind of compare what their utilization in Medicaid is versus before, and looking at uncompensated care reported in hospital financials. So that's sort of the next steps in digging into the data more. I think that's all we have, unless anyone else has questions or comments.
Thank you. And safe driving. Go home early. It's going to freeze up again.
Safe walking. Yeah, walking.
Do not. What do you say? Don't walk. Safe walking.
That's where the fracture.
Safe walking.
The fracture. Yeah, the fractured up.
Safe walking. Yeah, thank you.
No, I never consented to it being in German.
Whatever.
But until you get in a call, okay, so you can go ahead and I'm going to close this out, and it'll say lead webinar and webinar call. What you're going to do is you're going to web and then pay for every $100 million. And you're going to say, yeah.